Hey, everybody. Thanks again for joining me for another episode of Resiliency Radio, your go-to podcast for the most cutting-edge insights in integrative and functional medicine. I'm your host, Dr. Jill, and with each episode, we dive into the heart of healing, personal transformation, and really all things to do with optimal performance, longevity, and things to make your life and your health better and improved. Today, I am super excited to introduce a new researcher that I met through a conference recently, talking about the microbiome and microbial insults to our system, and actually doing the research out in the field to really give us as clinicians and you as a patient more information on how to combat chronic long COVID or complex chronic illnesses. You are going to love the show. Stay tuned. I promise you're in for a treat with Dr. Amy. Before we do, I just want to remind you, you hear me every week talk about drjillhealth.com, where we have curated incredible products for you for things like your vascular system, mast cell activation, chronic complex infections, allergies, gut health. You can find them all at Dr. Jill Health. And of course, Dr. Jill Beauty. Some of my favorite products are there, and you can peruse. My favorites is a really big seller with the collagen, HA collagen cream, the biopeptide, and the Vita CE serum. But today I just want to remind you, one of our very best sellers that's back in stock is this needle-free serum. Yes, this, if you're not into Botox, is amazing for these little fine lines. You can see I'm doing pretty well there. Around your face, this needle-free serum works amazing. You only need a couple drops, so the bottle lasts for quite a while, and you can find that at drjillhealth.com. Just check it out. Leave me some comments below. And as you know, if you have not yet subscribed, you can hit subscribe. Many of you listen and don't subscribe, and that is quite all right. This content is all for free, but you help me out, help me to get great guests and to reach more people. If you are on YouTube, hit the subscribe and join the over 570,000 subscribers that we currently have, and probably at the time of this posting, even more. Okay, without further ado, I want to introduce Dr. Amy Proal, PhD. She's a microbiologist and chronic disease researcher with expertise in systems biology, the human microbiome, and the role of persistent infections in complex chronic conditions. She is the president of Polybio Research Foundation, where she leads collaborative research projects focused on the molecular mechanisms driving conditions such as long COVID, ME/CFS, and post-treatment Lyme disease. She earned her PhD in microbiology from Murdoch University and has published extensively on the intersection of infection, immunity, and neuroinflammation. Her work emphasizes the importance of precision medicine and open science collaboration in tackling poorly understood disease. You are going to love this show. Welcome, Dr. Amy. Dr. Amy, I am so excited to have you on Resiliency Radio. Um, we have a lot in common, even though we've never officially met, and I'm so excited to dive deep today. I always like to start. I heard some of your personal story from some of the interviews you've done before, and I think that's so relevant because it kind of drove. So I don't know if you want to start there, but I would love to hear how did this adventure begin for you with complex chronic diseases and really bringing the research to the forefront?
Yes, no, I mean, and I don't tell my personal story as often these days, but I'd like to here and there. So, yeah, I mean, it's pretty straightforward. And I think that this experience has actually happened to a good number of people. But first of all, I'm a fraternal twin. And when I was a child, I grew up outside the country. So I grew up in Mexico City, Mexico. And I don't know if this had to do with it or not, but I got a lot of infections between the ages of 3 and 5. I got a crazy case of pneumonia. I got a terrible case of scarlet fever. I was hospitalized for a terrible case of meningitis. And my twin sister got none of these infections, right? Then after that, after the age of 5 and through high school, I felt largely fine. And I went on, I played sports. I was the captain of my tennis team. And then when I got to college, when I was in DC, I started to feel a little weird. I started to feel, I don't know, like I had more headaches, I had trouble sleeping. And of course, I mean, I think by sophomore year of college, I would go to the student health center and be like, hey, I don't feel great. And they would, of course, say, they'd run, I don't know, two things of my
Yeah,
blood work and be
CBC
like,
and
you're
be like, your
totally
blood counts are
fine.
fine.
Yes, you're
Yeah.
fine.
Uh-huh.
Are you eating well? Are you exercising enough? That's the only thing that could be an issue here, right? And I just leave, right? And so this went on for long enough. And then at the end of senior year, I got some infection, which I still don't know what it was. and got much worse and got very sick. So I was just really bad. I was pretty much bedridden. So I was there,
Wow.
couldn't tolerate light, couldn't even tolerate sound, just very, very sick. So laying there in my bed, I thought, what can be wrong with me? I mean, first of all, I got much sicker after an infection. Also, when I was a child, I had all those infections. I mean, is there a chance that any of these infections, first of all, could just still be in my body? Even the ones that I had as a child. I mean, could that be? Because part of the symptoms I had was actually profound flu-like symptoms. So I had like a sore throat that would surge and the feeling of fluiness that would come and go. So I honestly felt a lot like I could still have some kind of ongoing infection. And of course, I brought this up to a good number of doctors, and they were like, no, you don't. But then I began to be like, well, how do you know that? I mean, you're not testing me for any of these infections. Surely the infections could be, you know, in my brain or in my nerves or in parts of my body that you can't identify on your simple blood test. So, I don't know how you're coming to that conclusion. And so then finally, I started to become really interested in all this literature on chronic infection as a driver of chronic disease, which basically took me back to even looking at textbooks written in the 1960s or in the 70s, when honestly, there was a lot of energy on how different bacterial or viral or fungal or parasite organisms could drive a wide range of chronic diseases by persisting in a huge different number of human tissues. All of which really kind of came to some of a stop when the theory of autoimmunity,
Yeah.
which basically assumes the body is just sterile,
Yeah.
kind of took hold and knocked that research down. But I became interested in this other work. And so as I did that, I started a basic treatment that, people were doing, which involved using low doses of pulsed antibiotics
Mhm.
in a drug that basically via some modeling might support the immune system, which made sense to me.
Yeah.
And over time, I sort of improved on this protocol and a number of other sort of antiviral and antimicrobial approaches that I was able to use to improve my health a lot. And once that happened, I thought, well, look, I want to study this more. Originally, I'd wanted to become a doctor. And I was like, I don't really want to be a doctor. I don't know that doctors right now have that many tools at
Right.
their disposal to understand what's going on. I want to study these infections and I want to understand what they do. And that set me off to get a PhD in microbiology and then eventually to found Polybio, the research
Yeah.
nonprofit I lead that studies the role of infection in chronic disease and basically take me on that route.
I love it so much, Dr. Amy, because here I am in functional medicine, and I'm always saying it's toxic load plus infectious burden creating inflammation, immune dysfunction, right? And I'm in the clinic, I'm seeing the patterns, and I'm like seeing patients like you come in and say, my doc told me I'm fine. I've been to Stanford, I've been to UCLA, I've been to all these major medical centers. They don't know what's wrong with me. And I'm like, well, we can dig deeper and find out. And what we find is, and I want to talk to you about this, but I want to frame it because here I'm in the clinic. I'm not the researcher. And when I saw your research and I've dove into your website and then heard you speak on ICI, it was such a profound, like, thank you. Like literally, you can see I'm glowing here because I'm so excited
Yeah,
about the work that you guys are doing. Because what you do is you bring legitimacy to what we're seeing in clinical practice, and then we're down in the roots trying to find those root causes and find the meds and the herbs and the things that actually change the terrain. So how did this groundbreaking, I mean, obviously this your initial experience with being told there's nothing wrong and then realizing, oh wait, there is something going on. There's so much to talk about, but let's just frame like, well, how did you begin into this research and how did you really start to find? Because I saw your work on the tissues and how it check levels of different things. Because I really believe in functional integrative root cause medicine, personalized, precision, whatever you want to call it. These microbial infections and microbial effects on the tissues, in conjunction with our toxic load, are the root cause of most of our complex chronic conditions, right?
I agree. And that is also what I've come to think is at least the leading, hypothesis that we are looking at, right?
Mhm.
Which is exactly that starting in the womb,
Mhm.
really, where you can inherit from your mom. Let's say the mother, as a mother, harbors like a herpes virus or a different pathogen or bacterial organisms. Many of those can actually be passed from mother to child in the womb. So you can inherit pathogens even that set you up with that infection starting early in life. And then from that point on, you're exposed to all kinds of different infections. I mean, there are, first of all, just a huge number of respiratory infections
Yes.
in and of themselves, right? So we have, from RSV to the enteroviruses, which drive, let's say, hand, foot, and mouth disease, to all kinds of the different influenza strains, to, the coronaviruses. there's a lot of those pathogens that we know we are getting on a regular basis. Then there's all kinds of other infections that we carry by ticks, let's say, or
Mm.
vector-borne
Yeah.
organisms. So that's your Borrelia, the Lyme pathogen. There's Bartonella, Babesia, Rickettsia,
Hmm.
Anaplasma. Then, for example, there are the mosquito-borne
Yeah.
viruses. There are, West Nile. There are all these other pathogens carried by mosquitoes. Then there are parasites. There's, for example, just Toxoplasma
Yes.
gondii is a parasite. And this, just always blows my mind. Approximately, and this is the CDC, okay? Approximately 11% or more of Americans are understood to harbor this
Wow.
latent Toxoplasma parasite in their brains in a
Mhm.
apparently latent dormant state.
Yeah.
But I mean, come on, is it latent? Is it dormant? That's an assumption. Easily,
Mhm.
this parasite in people's brains could be doing something. And in fact, it is tied to be able to drive neuropsychiatric symptoms, symptoms that can even change people's cognition, that can change the way that they function mentally. And when we look at all these conditions of apparent unknown cause, neuropsychiatric diseases, neurocognitive symptoms, obviously, these parasites or bacteria or other pathogens that can literally modulate and drive neuroinflammatory symptoms have to be factored into the mix of factors that can be contributed in them, right? So, with all of these infections that we can sustain, and many of which we don't fully clear, and I think this is the biggest part of what we study, is there's a huge assumption that when people get an infection, it just clears after their symptoms go away, which, if you're a pathogen, isn't really what you want to do. Honestly, once you found a host, you kind of want to stick around. I mean, why not? Why not keep persisting in this person, at least in a low level, right? In a level in what we call often now a reservoir, right? Where, yeah, you don't have the pathogen maybe through every single cell and tissue of your body, but little amounts of the pathogen are persisting in parts of your tissue, in parts of your nerves, where they can still drive inflammation, where they can directly hijack the functioning of your mitochondria, which is a huge thing that almost all pathogens do, where they can drive all kinds of changes, even to the way our human genes end up signaling, right? They can change the way that our cells control our signaling pathways by creating proteins or metabolites that distort those pathways. So there are so many pathogens, there are so many mechanisms by which they can drive chronic symptoms that once you start to realize that, yes, it really isn't even implausible that they can be contributing to a wide range of chronic diseases. And then, like you said, mixed in the other environmental factors, right?
Yeah.
All the other parts of the exposome, the mold
Yes.
exposures, the chemicals, the other factors that either hold down the immune system or, drive their own dysregulation, they mix and match in with the infections, right?
Yeah.
We're one of, as you would know, the most common presentations of chronic disease is someone who's been or being exposed to
Mm.
mold, for example,
Yeah.
which is holding down the immune system and dysregulating the body's ability to detoxify correctly, and an infection that now they have more trouble clearing that can now probably persist better in their system, right? So all of these things are feeding into each other to be able to drive symptoms. And I do think that if we're able to understand that, diagnose them better, address them better, we stand to really reverse the epidemic of chronic disease that we're finally these days able to talk about more openly.
I could not agree more. And that's why, like, I love the legitimacy of the Polybio, the foundation that you've created, and the work that you're doing that brings to what we, like I said, because I'm just in the clinical practice, I'm not doing massive research. I just see these patterns, right? And then I hear someone like you talking and sharing your research. I'm like, yes, it's so helpful. And if anyone, is finding this hard to believe, just think about chickenpox. You get it when you're 5, or now nowadays you get vaccinated. But years ago, when I was that age, I got chickenpox. And then, you're 70, you have a surgical for your hip, and you get reactivation as shingles. Like, duh, in medical, even in medical training, we know these old viruses from literally decades can reactivate. That's not a question. And so I don't know why it's so hard to think about CMV, Epstein-Barr, any herpetic virus families, or these tick-borne infections. What do you make of, in my perspective, I think that compared to, say, 50 years ago, where there was maybe a little bit more nutrient-dense soil and less air quality issues and less mold and all this, we were better able to dampen down, like have our immune system actually keep these things in check, because it's not
Yes.
that we that they're always active, right? What would you talk about as far as the interplay between the strength of our immune system, the increasing toxicity of our environment, and why like we're seeing more of these reactivations and things popping up now than say several decades ago?
Yeah, no, you're right, because that is one of the things that somewhat stymied the field of tying chronic infection to chronic disease is that people, a lot of people, for example, harbor Epstein-Barr virus, right? It's one of these main herpes
Mhm.
viruses. You can get it, you get it from mono, the kissing
Yeah.
disease, right? Which, to me is interesting. Like people will get mono and they're like, and it's like, oh
Mhm.
man, look, Epstein-Barr virus is no
It's
joke.
no
I mean,
joke. And the
yeah,
autoimmune
it's
connection, right? I mean, there is
exactly,
lots of literature connecting it to MS and to
e-
neurodegenerative
exactly.
diseases.
Mechanistically to MS. I mean,
Yeah.
where this team at Stanford did a really good study, which shows that this protein created by the Epstein-Barr virus is really similar in size and shape to a human neuron protein in the brain that the immune system attacks in MS. But what really happens is that the immune system in the brain attacks the viral protein to try to target the virus, and then it cross reacts with that neuron protein because it's so similar in size and shape. It's kind of like if you were an army and you're firing on your enemy and they're wearing red, right? And then there's like civilians wearing red. It's like that's what's happening. The immune system's trying to get the virus protein and it hits the human neurons, but it's really actually going after the virus first and foremost, which places that infection yes, at the
Yeah.
heart of multiple sclerosis, right? So, okay. So these, overall, those viruses, a part of about 90% of people maybe or even more have Epstein-Barr
Mhm.
virus. So and not everyone's getting MS. So obviously, exactly, a lot comes down to how well your immune system can control that virus and say like, no, 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 no. Like you stay down, right? You're going to try to come up, be more active,
Yeah.
create more of those proteins, but we're not going to let you. We're going to keep you in check, right? And that's where, if the immune system is in bad shape, you have more and more of an ability for the pathogens to activate and become more problematic. And so, to speak to those factors, I mean, I definitely think that the toxic burden, it seems like it would have increased, for example, microplastics alone sort of blow my mind. I don't know. There are factors where we've so artificially added to what people are being exposed to on a regular basis where, just straight up science papers suggest at this point that people harbor a good amount of microplastics, often in the brain.
Mhm.
I mean, that just cannot be good. So I
Yeah.
think like factors like that where people are obviously exposed to vastly more plastics, to vastly more artificial materials are probably not helping out at all. I also do think that that mold is so overlooked that it's almost painful. I mean, at this point, I don't really know. I'm not an expert on mold to know enough of which buildings had mold before versus now.
Yeah.
But what I know is that, there are enough people when you start to actually test rooms for mold where it's so common and it's so ignored by the vast majority of people that the number of people that are just living in older housing now, there's a lot of water, there's a lot of wet. I mean, there's a huge propensity for there to be mold and other factors that are simply unaddressed, right? So, I mean, those are just some of the factors, although, I'm not sure. Like, the other thing too is that, we really are, I think, seeing probably more repeated infections than we've ever seen in history. And that's where, as much as the COVID pandemic, I understand why people are pretty over it and are tired of, that was a pretty bungled pandemic.
Uh-huh.
But at the same time, the introduction of SARS-CoV-2 into the population is not great. It's just
Mhm.
those two things can be true at the same time,
Yeah.
unfortunately. And we do study a lot of people with long COVID who get sicker after a COVID infection. And yes, some people do get sicker after the vaccine, but a lot of people really do get sick after infection with the virus too, right?
Mhm.
And so, unfortunately, we've even found that in a lot of our studies where we're able to get tissue samples from patients with long COVID, that virus isn't even fully clearing from people's tissues. This
Wow.
is one of the bigger things in long
Mhm.
COVID. For example, in the tissue of the gut,
Yeah.
which actually has a lot of the ACE2 receptors that the SARS-CoV-2 virus uses for entry, there's a couple teams that have gotten tissue from the gut via procedure from patients with long COVID and found double-stranded RNA, which is a type of the RNA the virus only produces when it's replicating in
Wow.
that gut tissue over 2 years after the person had COVID, right? So
Yeah.
the SARS-CoV-2 virus is even capable of long-term persistence, right? So
Mhm.
unfortunately, we even added this new player into the mix of other infections that people are already getting. So the fact that people get COVID and
Mhm.
then strep
Yeah.
and then RSV and then influenza and then pick up some kind of vector-borne infection and then have some other, I mean, the every single friend I know who has kids tells me these days that there are rare periods when someone isn't
Yeah.
sick. I mean, it's like a constant thing to be like, okay, someone's sick this week, someone brought this back from school, here's another thing. And that's not great because what
Yeah.
happens is overall, when you're dealing with one infection, the immune system gets caught up with that, right? Like whatever it is, your
Yeah.
T cells start to form to try to address that infection. The infection, the pathogen is trying to downregulate the immune system so that it can better persist or stick around. All of that isn't great. You get the next infection, your system is less equipped
Yes.
to deal with that one. Now, that one probably has a better likelihood of persisting and maybe not clearing. So you start to add into what sometimes I call successive infection,
Mm.
or each infection is starting to kind of compromise the immune system, compromise the system so that it makes it easier for the person to have a problem with the next infection, which then they can. And now, of course, they're going to be even more susceptible to mold, to other factors, to all these other things because their system is going to have trouble dealing with those. And then you go down this kind of downward
Yes.
spiral, right? So the fact that we just added one more pathogen, SARS-CoV-2, into this regular mix, that doesn't help either. It doesn't. So, and one of the things there that I think we could do to address this, I'll just go ahead and pitch this
Yeah.
now, is to clean indoor air. I just,
Yes.
if there is the lowest
Uh-huh.
hanging fruit that
Yeah.
I think a lot of people can get behind for even different
Mhm.
reasons, right?
Yeah.
We work with groups that
Mhm.
can create, excellent HEPA filters that
Yes.
truly filter a good number of
Yeah.
viral particles out of the air or have germicidal UVC lights,
Yeah.
which actually use a UV light that's
Mhm.
safe. I don't know. It seems to
Yeah.
be in studies, at least in like a very crowded space. You could put this
Mhm.
UVC light in. It literally kills
Yeah.
viruses in the air. So you can layer a room with
Mhm.
HEPA filters,
Yeah.
with UVC. You can
You'll
pretty
see.
much remove the viruses from the air and at the same time purify from mold better,
Right.
purify from all kind from wildfire smoke, from all
Yeah.
kinds of other factors that are also in the air that we don't want. And I think that to a point, I don't understand why we're not doing that more. Because, for example, if you look at water, right?
Yeah.
We made this decision back, not long ago to purify our water,
Mhm.
where, we obviously have water purification tanks, or even the government's behind this.
Right.
We clean our water, and then even when our water is supposedly pure and arrives at our faucet, we get an extra Brita,
Yeah.
we get an extra system, we're filtering it. We should do that with our air. We should filter our air too. If we did that, I really think we would lower the number of infections people get, and it's at least a good start. So there's things like that that I think are things that we could.
Hey guys, just a quick pause to remind you if you haven't yet subscribed, please click the subscribe button below if you're on YouTube. Hit the bell to be notified of future episodes. We know a ton of you listen and don't subscribe, and everything I produce here is free. So I'm just encouraging you to help us reach more people, attract amazing guests for you, and hit that subscribe button and join those people who've already subscribed here. If you are on iTunes or Spotify or any other platforms where you're listening to podcasts, would you stop by and leave us a review? That also helps us out. Okay, back to the show. Thanks so much. Low
Implement to sort
hanging
of,
fruit.
yeah,
I
low-hanging fruit.
love again, you're speaking my language. I always say clean air, clean water, clean food, and air.
Yes,
The statistics show 80% of the toxic load is through the air that we breathe. And this mold issue really is because of poorly constructed, constructed buildings, because of all the hurricanes and floods and things, because of, as weird as it sounds, mold is a living organism. And if it's in your
yep,
walls of your house, you have massive EMF structures that actual
yes,
signal will signal the mold that there's a danger because it senses it like a living organism, and it will actually produce more mycotoxins. That's been proven. So there's all these weird things that sound crazy, but actually have scientific validity behind them in the fact of why mold is becoming a bigger issue. And then, as you well know, some of the mycotoxins that mold produces, like mycophenolic acid, are like a known, they use it for a drug for organ transplants. So it's like a known massive immunosuppressive. So I could not agree
Yes.
more. Interestingly, during the pandemic, we had like five filters in our office, the HEPA, but like you said, the VOC, which is like 2.5 microns and below, which can actually help filter the viruses. We didn't have the UV lights, but that would be a great
Yeah.
step. I love just reinforcing that for people listening because it can be pretty simple to get a standalone filter, at least in your bedroom, or a UV light in your furnace. And these things you can have installed now. I could not agree more. Now, one thing I heard you talk about ICI that I thought was so fascinating and in my experience is so true clinically again is often after people would get COVID or multiple times, they would be very ill or have long COVID symptoms. And for me, it was differentiating, is this like a mast cell issue where the immune is dysfunctional and creating histamine prostaglandins? Is it more of a reactivation of some other infection? And I'm going to the study you quoted about Bartonella being reactivated
Hmm.
after.
Yeah.
And again, or is it just a long COVID causing inflammation and the spike protein retains? Do you want to talk a little bit about what you've seen in the research? Because, like I said, when I heard you talk, I was like, yes, 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 because it so validates what we see in clinical practice. And also the conundrum of, as a clinician, saying, is it reactivation of Epstein-Barr? Is it reactivation of Lyme or Bartonella? Or is it just long COVID and inflammation from that? As a
Mhm.
researcher, how do you view that kind of issue?
Yeah, and those are all the questions we're trying to
Yeah,
study.
yeah,
Exactly. So, I think the hardest part when you're trying to understand if the person still has the infection is that you can often not do it via simple blood tests at all, or even a lot of blood tests, because the pathogen, and let's say it's SARS-CoV-2, let's just say you don't even clear
yeah,
SARS-CoV-2. It doesn't persist in the blood where it's going to get targeted. I mean, if you're any pathogen and you're just free floating
right.
around in the blood, all the immune system will recognize you and kill you. So what all pathogens do is hide, especially over time, in tissue, where they get into your tissue, they burrow deeper into your tissue, sometimes infect a nerve, which is
Mhm.
great for them. They can kind
Yeah,
of hang out in that nerve. And then that's where they're at. And this is the problem is the person on their blood work and even via antibody testing
Mhm.
that for pathogens can seem negative
Yeah,
right when the organism is in tissue. With the antibody testing being problematic because when I told you before that the pathogens often knock down the immune system, what happens then is people who often have the most severe persistent infections have a compromised immune system and they don't form antibodies robustly, which indicate the presence of the pathogen. In other words, the immune system has to be strong to form good antibodies. So, ironically, the people who could have the infection most aren't doing that, right? So, a huge amount of what we've done at PolyBio when we're studying, let's say, SARS-CoV-2 persistence in long COVID is help research teams at different institutions collect tissue samples from people with long COVID or related chronic conditions tied to infection. So we actually have to go and do a lot more work to be able to get the permissions, let's say, for example, to do an endoscopy procedure where we're able to get the tissue from the gut of people with long COVID or a related condition, or to do a lymph node biopsy that gets a little piece of tissue from the lymph nodes where the pathogen would actually, again, be expected to be, right? We even have some groups getting, skin biopsy samples from people that have peripheral nerves in them, where we're able to look for infections there. People getting through a bronchoscopy procedure, lung tissue from people with long COVID. So via those studies of tissue,
yeah,
we're able to actually show in, honestly, papers that get noticed that the pathogen is still there. And if no one did that work,
yeah.
it would simply be assumed that they were not there, right? So the key part of one of the central parts of our polybio research program is this collection and study of tissue samples via procedures or even during surgery, right? And to the point where, our slogan, unofficial slogan is the issue is in tissue,
Oh, I love
where
it.
we really do want to focus on
Yeah.
that, right? But the thing is that, mast cells, which you mentioned before, which we know, right? There are patients with whether it's long COVID or chronic Lyme disease or infection associated chronic disease, where we know at least that when they take medications that control mast cell activity, so different, antihistamines, that their symptoms sometimes improve, which strongly suggests that mast cell activation is happening in them. But the thing to understand is that mast cells are the primary cell in tissue that's responding to any sort of environmental or unaddressed factors. So
Mhm.
if the person hasn't cleared an infection and there is a little reservoir there, the first cell really that's going to come in and say, hold on,
Yeah.
this infection is still here is a mast cell,
Yes.
right? And what happens is if you don't clear the infection, the mast cell keeps basically saying like, hey, it's here, and
Yeah.
it becomes primed, which can happen where now it takes on this sort of state where it's almost hyperactive. And the next thing that also the mast cell responds to it responds in like a overactive
Yes.
way because it's already been primed by the first sort of unaddressed factor. And I think that's what happens in a lot of cases is that someone doesn't clear an infection or something, the mast cells become primed now when they eat something, when they're exposed to another factor or whatever. Now the mast cells become activated and primed and so you get this cascading
Mhm.
activation of mast cells that could become a big problem. But the key there is that the mast cell activation doesn't have to be separate from the infections. I think there's a lot of people who will say, oh, this person has MCAS, right?
Yeah.
And they think of just the mast cells doing this in and of
Yeah.
themselves, which I suppose is possible. But I think that key to think about is that an uncleared infection would be one of the most logical reasons to have mast cells that keep activating. And so I think that the mast cell field needs to keep thinking about that connection because very likely if you address the infection or some of the other issues that are activating the mast cells, maybe you can then lower their activity without having to continually use the mast cell meds, right? So I think that intersection is important. And I think that, the other factors that we look at, for example, the co-infections like Bartonella, yes. So a key thing in long COVID cases, right, is that you have people who get COVID and get sick. All of a sudden they have chronic symptoms.
Mhm.
But if you think about what the SARS-CoV-2 virus does, one of the targets, especially of the spike protein, is that it has very detrimental impacts on the blood vessels.
Yes.
So
Yes.
SARS-CoV-2 is a
Yes.
blood vessel,
Yes. Endothelial, right?
very,
It's an
yes,
endothelial
an
target.
endothelial
Mhm. Yeah.
targeting virus. I mean, it
Yeah.
infects most tissue
Mhm.
types, but it truly just
Yes.
inflames,
The vascular.
damages the blood vessels.
Hmm.
So if you already have an underlying problem in your blood
Yeah.
vessels, you're more likely probably to
That's
have a problem
vascular, like
with COVID.
Bartonella, right? Yeah,
Exactly.
exactly.
So if you think
Uh,
through the pathogens that infect the vasculature, one is Bartonella, which is a pretty underappreciated pathogen that, this is one of the things with Bartonella is it's a tick-borne pathogen, so it can be carried by ticks. So you can get a tick bite, and in addition to getting Lyme disease or other infections, you can get Bartonella.
mhm.
But most people don't realize that you don't have to get a tick
Yes.
bite to get Bartonella. It can
I've
be
seen
carried by
spiders and
fleas.
cats and
Exactly.
fleas and even bed bugs, right? Like all of
Exactly.
those.
Just so
Yeah.
many other vectors that are very common. So I think many people, and this is even in the standard research community are starting to agree that Bartonella is underappreciated as an organism that a good number of people pick up. Now, it does seem that some people can carry Bartonella and remain fairly asymptomatic, a little like Epstein-Barr
Yeah.
virus. Not everyone who has that has the severe disease. But if something, again, allows that Bartonella to activate and emerge more, especially in the blood vessels,
Yeah.
you're probably going to deal with a lot more symptoms driven by Bartonella. And that confluence of SARS-CoV-2 and the spike protein,
Yeah.
whether it's from the virus or maybe the vaccine, targeting the blood vessels and having a sort of
July.
asymptomatic
Mhm.
Bartonella infection in the blood vessels is a brutal
A
combination. So
big deal.
we see increasingly when we test people for Bartonella who have a long COVID diagnosis that they are positive. And we're doing some work on that hopefully will even publish formally soon,
Mhm.
where we'll show that people who have a long COVID diagnosis have a high likelihood of having Bartonella, and not just Bartonella, actually even Babesia,
Yes.
which
Yes.
is a parasite,
Mhm.
another not very appreciated parasite, which can also, again, which is primarily carried by ticks, although these days I think we could probably study
Yeah,
more vectors on all of these bacteria. And Babesia infects the red blood cells. So does Bartonella, but Babesia
very cool.
infects red blood cells directly. So really, it's another pathogen that can become disrupted when you have another virus like SARS-CoV-2 that gets involved with blood vessel or blood cell
Mhm.
function. So Babesia is another one that I think we need to increasingly consider in cases where people are chronically ill.
I could not agree more because in clinical practice, just Lyme alone, which is the
Right.
classical Borrelia burgdorferi for those of you, which is, carried in the East Coast and Wisconsin and California. There's so many more infections. And even in my state of Colorado, it's not considered Lyme endemic, but we have a lot of tick-borne relapsing fevers, Babesias, Bartonellas. And so that awareness around, in fact, CBS did a little segment about 2 months ago and asked me to talk about, because there's lots of ticks in our area at that time.
Mm.
Like, does Lyme exist in Colorado? And I kept saying, it's about Lyme and the co-infections. If we just talk about Lyme, yeah, it
Yeah.
is more likely Connecticut, the classical Borrelia burgdorferi, but there's so many more tick-borne of these vector-borne infections that people are not thinking about. And yes, we have them in Colorado and Wisconsin and Wyoming and Texas and places that aren't typically endemic. So I
Yeah.
loved that you talked about the mast cells as these, because I always say they're doing their job, right? Like they just got
Right.
irritable. It's like poking a sleeping bear, trying to
Right.
protect us, and then it kind of
Exactly.
goes awry because whatever the nidus that was there to trigger them is still there in the tissues. And whether it's toxins or infections or both,
Exactly.
there's a new couple of papers out about toxicant-induced loss of tolerance, TILT, and it's this new term for kind
Mm.
of the old multiple chemical sensitivity.
Yeah.
And what it's saying is a lot of those things where people are super sensitive to chemicals and smells and everything in the world is really driven by mast cells. Well, I could make a case for, and I'd love your opinion as a researcher, that not only toxicant induced, but pathogen induced loss of tolerance, right? Same kind
Yeah.
of thing. Do you want to talk a little bit
Uh,
about how those, and how that mast cell and infection really play out and then become this perfect storm that's hard to stop, right?
exactly. I think that, yes, I think whenever you see an activated immune cell, what I always do is say why. Because their immune cells, our immune systems are on our side usually. And I think this is one of the things that we need to start thinking about more. Autoimmunity and the theory of autoimmunity has led to a lot of thinking in the world of medicine that, I don't know, the immune system screws up or the
Yes,
immune
yes,
system misfires or something, which is increasingly less shown to be true. Whereas the immune system actually exactly has a lot of smart ways of coming in and protecting us. So if you see mast cell activation, there's probably some factor. It makes less sense to me that the mast cell just goes
right.
crazy and activates. It makes a lot more sense that there is an unaddressed toxin, an unaddressed infection that the mast cell is actually correctly coming in to recognize. It's just that if you don't get rid of the toxin and you don't get rid of the infection, the mast cell doesn't know what to do after a while and gets overly activated, right? So I think that that is key to understanding the mast cell issues. I think, though, too, one of the factors in terms of just organisms in the human body and mast cell activity is that in addition to the single infections we can get, like the herpes virus infections and the Bartonella infections, we all have these huge ecosystems of organisms, the human microbiome,
Huh?
right? We have trillions of interacting organisms in our guts, but increasingly these organisms are understood to persist in the nose, in the lungs, in other body sites, right? Where we have these ecosystems of organisms, again, under conditions of immune function, they're
Mhm.
usually in a commensal or in a state where they're balanced. It's a little like a forest or something, right? Or a rainforest. If all the animals, yeah, they're eating each other and there's all kinds of relationships, but if the ecosystem is in balance, all of these relationships are playing out normally. Whereas if some factor throws off the
Mhm.
rainforest, now all of a sudden everything gets skewed.
Yeah.
That happens a lot where what can happen too is an infection, let's say even COVID again or another tick-borne infection. By dropping the immune function, now all these collective organisms in the human body can become imbalanced. And when that happens, you have all these other organisms in the gut or other body sites that can themselves become problematic in the barriers of the gut. When people are talking about, for example, leaky
Yes.
gut or whatever, yes, I mean, if the ecosystem in the gut starts to skew to become in and of itself, like now pro-inflammatory or start to create metabolites that are actually not helpful for our human signaling, the inflammation from that can wear down the barrier of the gut, or sometimes this can even happen in the mouth. And now those organisms can spill through those barriers into the blood, where even they can get probably transferred
Mhm.
into tissue. So a lot of what can be happening too that activates mast cells is that microbiome ecosystems and the wear down of our barriers and the gut barrier, the oral barrier allow organisms to leak into the circulation and increasingly even get into tissue in a collective
Mhm.
sense that might also be perpetuating mast cells more often in a way that can add to this picture of them being activated in ways that are difficult. So, in that sense, sometimes approaches that help restore gut microbiome health, I think, can also be useful in cases where people have activated mast cells because it's one area where you can intervene somewhat to get that microbiome back in shape. And it's sort of like one factor you can stabilize as you sort of address the different hits, if you will, that can keep the mast cells perpetually active.
Well, I love that because I think with the muscles, just as you hit on, it's not just whack-a-mole and hitting down the muscles because we use H1
Yeah.
blockers, H2 blockers, mast
Yeah.
cell stabilizers, all these things, and it works. And most people need multi-layers. But if you don't ever address that thing that's triggering them, you're just going to be on, 7 meds for the rest of your life,
Right.
which isn't really sustainable. I love that you brought in the microbiome. I was going to ask about that, and I do think that's a great target. So I want to talk just a little bit about tissues because that's been your research. And so before we kind of wrap up, two things. First of all, one thing that I noticed in researching your research was
Yeah.
I really love that you have been able to find all these various people that are doing their own research and don't know about each other and kind of start to bring, like, you really have a great systems biology thinking that a lot of researchers don't.
Yeah.
What's been the most surprising as far as finding out who else is out there doing some research and how have you kind of put it together with the Polybio Research Foundation?
Yeah, exactly. That's what I love to do, actually. It is my passion because science does lack big picture thinkers. I'll
Yeah.
just say this because no one in science training is encouraged to do that. So, what happens is if you go into training as a scientist early on, you're advised to specialize. So, people will study, for example, like the characteristics of a single T cell and what it does, and they'll spend their careers understanding that one immune cell and all of the facets of what it can do, but maybe not the larger picture in
Yeah.
which this T cell is doing things with other factors that are also happening in the human body.
Yeah.
So what happened to me is that when I was doing my PhD in microbiology,
Mhm.
I was still a little bit sick. I had some symptoms, so I was allowed to do part of the PhD as a literature-based PhD and also where it was the early days where we were starting to use computers to identify organisms in the human body. And it was cool that I did part of this training at the J. Craig Benner Institute, which is a group that we still work with researchers there. And basically, what you can do is you can get a sample from someone, you can pull the genetic material out of the sample, you put it into a computer, and then you read the sequences, like the computer maps them
Yeah.
to the backbones of different pathogens. And this was starting to happen
Wow.
right when I was getting my PhD, and I was like, that's
Amazing.
cool. So I was able to do part of my PhD that way. And as I was kind of integrating then into the PhD a couple different topics, which I was allowed to do
Huh?
as part of this, I realized how labs that are even next to each other don't even know what the
Mhm.
other lab is doing. Like there would be one lab working on a topic who didn't realize that the people next door had the machine or the samples that they needed to answer the rest of the question they were working on. There was just such segmentation between groups that it's maddening.
Yeah.
So, what I did decide to do was by creating Polybio as a foundation to stay in a big picture role
Yeah.
and to basically be the person that, along with some of our core team, looks at the whole space and figures out, who's doing
Yeah.
cool research on different parts of the picture we're talking about. Because we talked about all these different
Yeah.
hits and all these different players in people's cases. So to really understand the full picture of chronic disease, you have to have groups working
Yes.
on those different factors, and they obviously have to be talking to each other.
Yeah.
So that's what we do is we look at the literature and we say, like, who published that study? That was really good. We just reach out to them and say, hey, for example, a lot of the teams that we brought into the long COVID space actually came from HIV.
Wow.
Because when we were looking at the fact that SARS-CoV-2 doesn't fully clear from some people's tissues, the people who most understand how to find viruses in tissue are actually the HIV world. So we would go and approach those groups and say, look, you know, the method you're using where you can use this cool probe to find
Uh-huh.
HIV in this tissue sample, can you do that with SARS-CoV-2? And they're like, yeah, I think that we could. And we help guide them to basically
Yeah.
begin to work on new topics. And then we basically make sure that the teams working on the projects we support talk.
Yeah.
And so we've hold, meetings where, for example, one team will present what they're working on, and then other people give feedback and thoughts. And we created a consortium, at least for long COVID, called the Long COVID Research Consortium, where we really are a group of scientists working together, sharing our ideas, sharing our data, which is great.
Yeah.
And part of that too comes down to the fact that we also share samples across sites
Yeah.
because some groups can collect certain samples more easily. Some groups have better methods for certain types of tissue. So by integrating all these networks across sites, I think number one, we understand a lot more and we also save a lot of time
Yeah.
and we save a lot of effort. So I think that that's key to science is that because the human body and all of our systems are so interconnected, and because there are so many parts of what causes human chronic disease that interact with each other, the teams that study
Mhm.
chronic disease also must interact with each other.
Yeah.
So that's a lot of what we work on.
That was one of the most impressive things that I read. And of course, I heard you speak about that because so many researchers aren't. It's kind of the same in medicine. We have rheumatologists, gastroenterologists,
Exactly.
neurologists, immunologists, and no one's talking. We're like, wait, this is all connected, right? It's like it all works
Definitely.
together, and we need your specialty and mine and everybody else. So, lastly, before we ask, let people know where they can find you, how they can support your research, do you want to talk about any sort of whether it's microbiome targeted therapies, immune modulation, or what from your research? But if you were to talk to clinicians out there, which I have a lot of people who listen, what would you tell us to be thinking about or watching for as far as how do we actually treat these patients?
Yeah. One of many interests and one of the things that we're studying is how medications that impact mitochondrial activity might actually help to control infection. And part of that comes from the fact that, and I think this is key to understand, is that every pathogen, especially viruses. So viruses are actually called obligate intracellular parasites, which means that they cannot replicate. They cannot create a new version of themselves at all without infecting your human cell and
I see.
pulling the substrates that they need to create a new version of themselves out of your human mitochondria. And thus, when they do that, they skew
Yeah.
the activity of mitochondria. I mean, as they pull substrates out, the way that the mitochondria can signal after that is messed up. It's
Yeah.
hijacked. So inevitably, and that, it's not just viruses, bacteria, as part of the way they replicate, as part of the way they stay alive at all, they have to gain, again, their nutrition substrates from your mitochondria. So
Mhm.
all of these pathogens are continually hijacking your mitochondria and changing your mitochondrial output is part of what they're doing. Now, one of the main pathways that they dysregulate as they hijack your mitochondria is the mTOR pathway. So
Yes.
mTOR is this, kind of key pathway that does a lot of things, but is connected to mitochondrial metabolism and mitochondrial function. And pathogens, not, as a whole, like a lot of them upregulate mTOR signaling as part of this mitochondrial hijacking, which means that mTOR inhibitors, for example, rapamycin, might actually stabilize mitochondria in a way that makes it much harder for pathogens to do that hijacking and gain those substrates, gets
Mhm.
in the way of it. Again, we need more research on this,
Mhm.
but we're running a trial of low dose rapamycin. This
Yeah.
is key, low dose, because
Yeah.
in a high dose, rapamycin is
Mhm.
immunosuppressive. In a low dose, there's fascinating work that shows that rapamycin taken once a week in a low dose or rapalogs, which are
Yeah.
compounds similar to rapamycin, might actually support the immune response. So, for example, there's one team who in healthy older adults, they gave the adults rapamycin or low dose rapamycin, or in some cases, these rapalogs. And in two trials, at the end of taking the rapamycin or the rapalogs, a couple things happened. The people had a stronger, they gave them the influenza vaccine, sorry,
Uh-huh.
but they had a stronger antibody response to the influenza vaccine than the people who had not been given the low dose rapamycin. Another thing is they measured T cell exhaustion.
Mhm.
And T cells, when they're exhausted, which is often because, again, they're trying to
Mhm.
address an unrecognized infection, express these markers of exhaustion that you can measure.
Mhm.
And they found that people who had taken the rapamycin or rapalogs had less T cell exhaustion, which was very interesting. And last, one study found that interferons, which are parts of the immune system that are key in controlling and keeping infections in check, were upregulated. It was a
Wow.
stronger interferon response. And part of that, this is our thinking, but part of what we're trying to study is maybe by stabilizing mTOR signaling and getting in the way of how pathogens can maybe hijack that mitochondria, you get in the way of the pathogen to survive and replicate, which basically gives the immune system a break, allowing it to come back up to better create interferons, to be less exhausted on the side of T cell signaling. So that's what we're looking at, which means that drugs, not just like low dose rapamycin, could be beneficial for people with infection associated chronic issues. Metformin, for example, is
Mhm.
another one that's interesting. So, for example, in long COVID, one trial actually showed, because obviously, key to preventing a lot of infection associated diseases, if you treat
Yeah.
when the person gets the infection, which we don't do enough of,
Mhm.
you could prevent progression to chronic issues.
Yeah.
And so there's a trial in acute COVID where people were given metformin.
Uh-huh.
And that is the trial that has one of the most signals of preventing people developing long COVID. And really, then you start to wonder, well, metformin must also have antiviral properties. So again, it's
Yeah.
possible that metformin gets in the way of the ability of pathogens to modulate mitochondrial metabolism to survive or replicate. So one of the bigger trends that I think is going to be using some of these, you know, medications that impact mitochondrial metabolism that are even used by the longevity space to
Yeah.
promote health span or lifespan, but in patients with infection related issues to probably be able to help possibly support the immune system on those patients.
Wow, that's just mind blowing. And my mind goes so many places because I think a lot of times we think of like as functional medicine, anti-aging, longevity
Yeah,
clinicians, how do we upregulate mTOR? Obviously, we need autophagy as well, but we might support the mitochondria where it's actually potentially the opposite because of the hijacking. So
yeah,
that's totally exciting. And then the T cell exhaustion is something we see in clinical practice a lot as well, where these just get obliterated, or the
yeah,
persistence of the spike protein in the macrophages,
yes.
whatever. Well,
Yeah.
I have so enjoyed this. We're going to have you back, but for now, if people are interested in learning about your research, donating to the foundation, or finding anything about you, can you give us your website and maybe any upcoming opportunities or how people can support you?
Sure. I mean, our website is polybio.org. And, I mean, there's a donate button right there. You can donate, which is really, truly helpful for us. But also, yeah, I mean, that would be the main thing. We have a couple of projects. Our focus now, of many, but one that we're really excited about is we're trying to help teams create accessible diagnostics to better diagnose infection. And
Oh,
I think this is key is we are tired of the tests that you as a clinician even has access to being so bad. We want
yes.
to improve the diagnostics. This is possible. It's just not, it's a matter of how much we care. So part of you're interested in better pathogen diagnostics, we have some specific projects that we're doing to do that. And so if you contact us through our website where we have an info button, we can give you more information on those, which would be huge.
Cool. I love that. I'll do everything I can to get the word out because this is
Cool.
just like a big game changer, your research and then what we're seeing. So thank you again for your journey and just for seeing that, having the insight to see this importance of big picture, the importance of pathogens, and the importance of actually doing the research so that we out here in the field of clinical practice can use that to help patients. It's just been amazing. Hey, everybody, thanks so much again for joining me for this episode of Resiliency Radio with Dr. Amy Proal, with Polybio Research. What a phenomenal amount of information. I know if you're a patient out there, you can resonate. If you're a clinician, hopefully this is a big aha and a wow moment for you to really put this all together. I know I mentioned a few times the things I see in clinical practice, and it was so exciting to first hear Dr. Amy talk about their research because what they're doing is actually validating the complex chronic illness that I see in clinical practice and the where the things come together with toxic load and infectious burden. And I love that she's even thinking about mold, as you well know, one of my favorite topics, and these infections that can pop up and cause illness. So I hope you'll reach out to her and just support her in any way that you can. If you are watching on any platform, platform or on YouTube. You can find the links in the show notes below. And if you haven't yet, hit subscribe. It helps us get amazing people like Dr. Amy on the show. Please hit subscribe or leave a review wherever you listen to podcasts. And we will see you again next week for another episode of Resiliency Radio. Thanks so much.